Hi, everyone, and welcome back. Our next talk will be Bronchoscopy Plus, focusing on endobronchial and transbronchial biopsies. An endobronchial biopsy is a forceps biopsy of a visualized endobronchial lesion. The main indications for this procedure are a visible intraluminal or mucosal abnormality, or for workup of suspected sarcoidosis, even with normal appearing mucosa. Bleeding and its sequelae are the main complications associated with endobronchial biopsies. This procedure is highest yield for diagnosing sarcoidosis and malignancies that are visible within the tracheobronchial tree. Yield is improved with 3 to 5 endobronchial biopsies. Transbronchial biopsies are forceps biopsies of the distal lung tissue that cannot be directly visualized, so fluoroscopy is often used during this procedure. Indications for transbronchial biopsy include pulmonary infiltrates, particularly those related to suspected infections, interstitial lung disease, or lymphoma, and pulmonary nodules and masses. A variety of forceps can be used for both endobronchial and transbronchial biopsies. These include cup, central prong, and alligator/serrated forceps. When taking an endobronchial biopsy, you will put the forceps of your choice through the working channel and advance until you can see the forceps tip in your field of view. You should take care to advance the forceps through the working channel carefully and have your scope oriented at a safe distance from the target to avoid the forceps hitting the lesion in an uncontrolled manner as they exit the working channel. Once you have the forceps in place, approach the endobronchial target in a controlled manner. You will ask your assistant to open the forceps and advance with the forceps open to engage the tissue as much as possible. You want to keep the scope close to the target while doing this. You will instruct your assistant to close the forceps, and once they are fully closed, retract the forceps by pulling them through the working channel. As you retract the forceps, you may feel a tucking sensation. Deep submucosal biopsies are performed in a similar manner, first wedging the open forceps onto the target areas, pushing the forceps to dig into the tissue, and then closing the forceps before retracting them. This is an example of a mucosal abnormality that is seen along the wall of the left mainstem bronchus. Cup forceps, or those with a central tooth, can be used to anchor onto the endobronchial lesions along lateral walls, such as this one. Next, we'll go into the details of performing transbronchial biopsies. When performing transbronchial biopsies, the biopsy forceps are advanced distal to the tip of the scope and into the distal bronchi in the periphery of the lung. This allows for sampling of the pulmonary alveoli. Since the forceps are advanced past the limitations of direct visualization with the bronchoscope, fluoroscopy is used as an adjunct to visualize the forceps as the biopsy is being performed. The diagnostic yield of transbronchial biopsies varies greatly depending on the underlying pathology. Diagnostic yield is greater than 75% for sarcoidosis, alveolar proteinosis, lymphangitic carcinomatosis, pneumoconiosis, PCP, CMV, lung rejection, bronchoalveolar cell carcinoma, diffuse pulmonary lymphoma, and hypersensitivity pneumonitis. Yield is also fairly high for nodules that are greater than 2 centimeters in size, with 60% yield for lung cancer and 50% for metastatic disease. Diagnostic yield is lower for nodules smaller than 2 centimeters, benign nodules, and interstitial lung diseases. Of note, fibrosis that is seen on pathology from a transbronchial biopsy is a nonspecific finding and is not diagnostic for interstitial lung disease. In terms of contraindications for transbronchial biopsies, the same general contraindications for bronchoscopy still apply here. The only absolute contraindication is refractory hypoxemia. There are also some additional considerations that are relative contraindications for transbronchial biopsies specifically. These include uncontrollable cough, untreated bleeding diathesis, renal failure, pulmonary hypertension, significant hypoxemia in a patient with one lung, extensive bullous changes in the areas to be biopsied, or radiographic findings suggestive of a vascular malformation near the intended areas to be biopsied. Of note, the absolute pulmonary artery pressure above which the risk for transbronchial biopsy is prohibitive is not known. The primary complications of transbronchial biopsy are bleeding and pneumothorax. Significant bleeding is considered greater than 50 milliliters and occurs in 1 to 2% of cases. There are a number of risk factors for bleeding and complications with transbronchial biopsies. These include coagulopathy, platelet dysfunction, thrombocytopenia, specifically with platelets less than 50, uremia, immunocompromised hosts, and the use of anticoagulation or antiplatelet medications. There's also thought to be an increased risk of bleeding with congestive heart failure and pulmonary hypertension, though these risk factors are not proven. Pneumothorax occurs in 1 to 4% of cases and may be immediately recognized in fluoroscopy or delayed. Depending on the size and how symptomatic the patient is, you may be able to observe versus place a chest tube. Overall, death is fortunately rare at 0.04 to 0.12%. Let's talk about the technique for random transbronchial biopsies. The first step is to wedge the flexible bronchoscope in the bronchus of your choice. You will then advance the forceps under fluoroscopic guidance to locate the pleura. Next, pull back on the forceps about 2 centimeters to the level of the terminal bronchiole. Open the forceps and then advance the open forceps slightly before instructing your assistant to close. Pull back on the closed forceps gently while keeping the bronchoscope wedged and retract them completely from the working channel to obtain your biopsy sample. By advancing the bronchoscope as the forceps are withdrawn, the scope is maintained in the wedged position. There is no need to pull the forceps quickly or forcefully up into the bronchoscope. There are also a couple of considerations in regard to pulmonary anatomy that can be helpful when performing transbronchial biopsies. For instance, the lingula and right middle lobe have proximity to fissures, and therefore transbronchial biopsies in these areas carry an increased risk for pneumothorax. For diffuse infiltrates that involve the lower lobes, biopsies from the lateral segment of the lower lobes are preferable because of the position of the forceps relative to the chest wall, which can be seen fluoroscopically.